Our next panel will be moderated by Phil Wolfson, and the panel is entitled Ketamine in Clinical Practice, Varieties, Research, and Opportunities. I'll let Phil introduce himself and the other panel members. Please welcome the rest of the team.
So welcome to what we hope will be a truly exciting panel and discussion. We're going to leave quite a bit of time because ketamine really is a burgeoning field. It's a field in which there are great opportunities, confusion, and a lot to think about and a lot to learn. And with a panel of this sort, you'll get a variety of experiences and opinions, and we hope that will be useful and it will lead to audience participation. So without further ado, I'd like to introduce our four panelists. I'll introduce myself. My name's Phil Wolfson. I'm a psychiatrist in practice in the Bay Area for many, many years. I'm the author of the Ketamine Papers, which some people now call the Bible, but I don't like the analogy because I'm an atheist agnostic, so don't call it the Bible. But it's doing well, and we're happy to have it out as a volume that seeks to represent the varieties of ketamine practice and its opportunity. Chadi Abdallah is going to present on science, and he is Associate Director of Research, Assistant Professor of Psychiatry at Yale University, Director of Neuroimaging, and Director of Clinical Trials in the Clinical Science Division. Raquel Bennett next is really a progenitor in all of this. She's the organizer of the 2 Korea conferences with an upcoming third, which really brought together practitioners of ketamine work for the first time and set us afire with new ideas, with controversy. And she is a practicing psychologist working with, as she'll describe, intramuscular ketamine, predominantly in different dosages, and is an avid pursuer of this field and a generator of more and more knowledge about it. Then we have Richard Roston and Alison McInnes, who are both Kaiser pioneers, Alison being the pioneer of pioneers and bringing to Kaiser ketamine work in the intravenous matter and really pushing it so that now we have 8 centers at Kaiser doing this work. Alison is a psychiatrist. Unfortunately, I left her out. She's a late but most welcome addition to the program. And Richard is the East Bay Ketamine Program Director for the Department of Psychiatry, Kaiser Permanente. So you're going to get a lot of different kind of views. So let me go back one. So the excitement of this is that off-label psychiatric use of the dissociative anesthetic ketamine, which we'll come back to as an essential property, it's burgeoned. Its clinics are coming up everywhere. And there are really kind of a spectrum of approach from using ketamine in what I call a black box approach, where you give the medicine often has profound effects, and you give it in a programmed way, which is bloomed, as you'll see, from the variety of practices into many different kinds of practices, but basically where it's administered without too much regard for psychological change and psychotherapy. The drug does the work. At the other side of the spectrum is what I'm going to particularly focus on, which is assisted psychotherapy, where we can use the medicine in different ways to evoke consciousness and change that's actualized in the moment of the work. Ketamine is being used for as many varieties of diagnoses and existential issues, lovelessness, hopelessness, bad relationships, and the diagnostic entities. We see it as becoming a primary treatment for depression rather than as it's been rubricized into a treatment-resistant depression format, which means that 2 or more traditional antidepressants have failed. It's been used in bipolar 2, PTSD, OCD, and others. We have a large review in the book that is from May of 2016 that Cole Marta and Wes Ryan and Ralph Koech did, if you really want to catch up on the varieties of ketamine. So the strategy of minimizing psychedelic effects competes with strategies that utilize the psychedelic property of ketamine. Hey, Blipper. There we go. I'm doing two things at once here. So let me go back to the opportunity, if I can do that. What's happening? Get me back. Well, the opportunity is that ketamine is the first. Can you get me back? Okay. Let me go back one. The opportunity is that ketamine is the first really new psychiatric drug in practice on a different mechanism of action that we've had in decades now. So it really changes the field. Initially worked up for the treatment of treatment-resistant depression. It is now in consideration for so many different things, even anorexia. And if you really look at the depression opportunity, I've just tried to lay out an imagination of the numbers of people that we're talking about. 16 million people annually, according to the NIMH, have depression. If 50% come to treatment, that leaves you 8 million. If 4 of those million folks don't work out because 25 to 50% of people fall into TRD, then you have 4 million potential patients nationally. So if you look at the Bay Area as 1% of the population, that's 40,000 people every year potentially for treatment. If you quibble, it's 2 million people nationally. So it's enormous. Then if you look at how ketamine has been propelled through its various formats, the original psychiatric use was psychedelic, begun in the 1970s. We'll be presenting a lot on that tomorrow. In the late 1990s, the NIMH came to the fore, recognizing it as a potential treatment for depression with a unique mechanism of action, and proposed a protocol using 0.5 milligrams kilogram IV dripped over 40 minutes. So then this was a single dose session with very short-term results on the average, but often an immediate effect, which suggested, its potency for treatment. This was extended to multiple sessions. Now, often we do 6 or more sessions. We do the same in our oral method or sublingual method, repeatedly for 6 sessions in about 2 weeks' time. This is common in IV fusion centers, and outside of Kaiser, you can see the kind of economics of this. Often it's in the new clinics, for instance, in San Francisco, there are 2 new clinics run by anesthesiologists, and they often do put other things together with this. Sometimes there are boosts, so the method is no longer inviolable. There's increasing dosage. I just saw an IV patient come to us, and she had gone up to 2.5 milligrams per kilogram, which is totally psychedelic, even over 40 minutes. So follow-ups may extend out to months and more. There may be psychotherapy, meditation sessions, and often practitioners may have no personal experience with the drug, or they may. So there's Steve Ross has been doing an ER bolus study of 0.3 milligrams per kilogram. At NYU, there are higher dosage sessions people do as boluses. The IM sessions that we do range from 0.25 milligrams per kilogram to 2 milligrams per kilogram, even higher. These can be compressed. Terry Early, a pioneer in this, has done as many as 2 or 3 IM sessions in a week or every week, weekly for people, very complex people. So there's no singular pattern in all of this. And I'm hyping my own program. An important addition to our methodologies is the use of oral sublingual administration within a psychotherapy format. And then coming ahead, a misspelling, Janssen is with 2 S's. Janssen's intranasal S-ketamine preparation is patented. We don't know how it's going to be. Most of us think it's bogus. Sorry, Janssen. Go back to pharma world. But we think that the RS mixture, which is economical and widespread use, has no reason not to be changed. And intranasal has its complications in terms of potential for misuse, which brings us to the fact that ketamine is a street drug in widespread use. Tomorrow I'm going to show a film on a Chinese village that became wholesalely addicted because they were making this stuff with the help of authorities and sending it out to the world. A lot of the illicit ketamine does come from China. There's rumor that it comes from North Korea, but we haven't proved that. So there's some IV and IM use in the population. Most people do bumps or snorts, and certainly there's addiction, and there are high levels of use which can produce urinary tract damage. All routes may lead to the K-hole. So I'll go through this quickly. So we have developed, Joanne Andrews and I in our Center for Transformational Psychotherapy in Marin, a practice of using a low-dose trance elicited by lozenges which enable people to stay conscious and work with us. And there's a threefold amazing tendency of ketamine work, which in some ways, because we come from MDMA work, has similarities. We've been operating mostly as a couple, man, woman, handling this. It's a good idea to have opposite sex when you do ketamine because people are in trance or in a state of near unconsciousness. You don't want to have any illusions to having done anything inappropriate. But the threefold tendency is a timeout from ordinary mind. So people are not in their usual mind. They have relief from obsession and depressional thinking. There's a reduction or even elimination of negative thoughts, and a reduction in thoughts itself. This opens the door to new life, new feeling, as well as doing abreactive work. It leads to an absence of dysphoria, a sense of relief. And sometimes these effects are miraculous. We've had people come off the bed after 15, 20 years of depression, 10 years of depression, and say, I'm a new person. Now, it's also true we have to maintain that. So the miracle has to be supported over time in general. So it's a work in process. We particularly have a history of over 100 patients and many hundreds of sessions and more than 1,000 at-home sessions. Of course, uniquely, we send people home with the lozenges, which can't be abused. You can't stuff that many lozenges in your face. It really is unpleasant. So you can do about 3. If you're lucky, you do 4, and then you drool all over the place. So it's very safe. So our interest is in understanding ketamine's use and its effects in a variety of its applications. In order to facilitate best practices and most effective outcomes, we're doing the first, we hope, what happened to our slide now? Whoa. Wow, that was a ketamine moment. You could feel it. Just everyone went to sleep. So, we're really interested in getting data from the whole field so that we can really know what we're doing and really come up with best practices. I can describe that to you later. Ketamine sessions, sublingual and IM, offer a unique opportunity for the development of psychotherapeutic strategies. Wow. This is very exciting, you know. It must be DEA doing it or something, I don't know. Somebody's working with us. Okay, let me try back again. Okay, I'll have to just tell you what this slide is about. Beyond the trance state and the crescendo of ketamine's effects on mind, everyone will eventually have a dissociative psychedelic transformative experience. We'll try this again. With appropriate preparation and dosing, this experience is safe, accepted, powerful, unique, may be powerfully antidepressant. It's an opportunity to think, imagine, and feel differently. Ketamine work at this dosage, you're conscious of what your experience is, you follow it, you may not remember it when you come out of it, but you're out of your body. The essential aspect of this experience is you're formless. The Tibetan Buddhist really desirable state. You're formless. And so you're in your form as energy, and that's a whole new experience for all of us. Unlike ECT, there's swirling imagery of all sorts. So we see this as a profound psychotherapeutic tool used in a dosage format that gives the experience but preserves observer consciousness and minimizes side effects. The IM method is the second path in ketamine-assisted psychotherapy, and we tend to use both low-dose trance and IM together for our effect. Considerations going forward, this is a list, that we'll all deal with probably in our sessions afterwards when we have audience participation. There are issues of economics, issues of administration, and issues of efficacy. So I thank you for all of this. It's been a pleasure to put all of this on you, and I pass the wand to Chadi. Thank you.
Thank you all for joining us. Is the mic working? I think it's working. Good. We're going to have my slides.
The pointer is on the top.
We will have them. So let me start by telling you what I'm going to talk about today. So today I'm going to actually focus on what we think is the neurobiology of ketamine, mainly how ketamine affect the brain, and before that, how depression and stress and trauma affect the brain, and what we think ketamine is doing to reverse this abnormality. And largely what I'm going to talk about is mainly based on preclinical findings that seems to be supported by clinical and biomarker evidence from human studies.
You're still on me. I'm not that egocentric. It's the PDF. Sorry.
So maybe I can.
There we go.
Okay, here we are. I can get started. So this is not the first slide? Oh, okay. Good. Is there a way to make it full screen so we can see it? I like full screen. Okay.
Can we separate the Mac from the other kind of people? This is actually Word, MS. Why don't you just go to the first one and try?
I think if...
Just try.
Okay, perfect.
Yeah.
Good. So that's an indication that ketamine works eventually. Although it's a rapid-acting antidepressant, but it's a slow-acting slide. What we think about depression and the neurobiology of depression is actually most of this study, preclinical study, was done with the mind that these are relevant to depression, but in reality these are relevant to most trauma and stress-related disorder. Most of these preclinical models is really model of stress. What's the effect of chronic stress on the brain? And here we see one of these models. Mainly in summary, we think that depression and chronic stress lead to dysregulation in the glutamate neurotransmission. And Glutamate in neurotransmission will lead to spillover, mainly increase of extrasynaptic glutamate, and this increase in extrasynaptic glutamate will lead to excitotoxicity and eventually to synaptic disconnectivity. So if we look at the right side here where we see the neurons, on the top neurons is this from a control animal. So you see the branching of the dendrites, and you see compared it to the animal that was exposed to stress for about 4 weeks. So you see a reduction of branching of the dendrites. These dendrites are shorter, and if we zoom in on it, we see that, let me see if I have a pointer. So if we zoom in here, we see that the spines where these synapses occur, we have much less of these spines. So this form of excitotoxicity eventually leads to disconnect between neurons, especially in the prefrontal cortex. So I want you to remember 3 things about the glutamatergic synapse. First, that the glutamatergic synapse, which is depicted here in this cartoon, the majority of the cortical synapses are glutamatergic synapses. Up to 90% of the synapses in the cortex are glutamatergic synapses. So even when you give a person a serotonergic psychedelic, it's eventually they're going to work on the behavior by modulating these glutamatergic synapses. So almost most of our behavioral and psychology is affected by these synapses in the brain. The second thing to remember about the glutamatergic synapse, that glutamate inside the synapse is beneficial to the brain. And this is how, for example, we have long-term potentiation, or this is how we form memory, or at least that's how we think we form memory, that you have this intrasynaptic activation of a glutamate, and this intrasynaptic activation will label this synapse as important synapse, and the brain will make it stronger and will make more of it. Unfortunately, that if we have a spillover of this synapse, mainly overactivation of a glutamate, we have a spillover extrasynaptically. This spillover of a glutamate in extrasynaptic space will lead to excitotoxicity. So glutamate inside the synapse is good for the brain, and too much of glutamate, which will lead to a spillover, will eventually lead to excitotoxicity and the disconnectivity that we talked about following chronic stress. So in this model, if you're subject to acute stress that you can let go and move on with your life, the acute stress is beneficial to your brain, will make more synapses, and will make your synapses stronger. If you're subject to trauma, even if the sexual assault is transitional, but you have this sustained threat in your brain, you are subject to chronic stress, and this will eventually lead to excitotoxicity, and this will reduce the synapses in your prefrontal cortex. So how we think antidepressant work is by, first, we think that depression will lead, as we can show in the preclinical model, as we can show in a human. For example, you can measure hippocampal volume, or you can measure gray matter in the prefrontal cortex, and you see a reduction. So we think trauma, stress, and depression will reduce the strength of the synapses and will reduce the amount of synapses. And ketamine and other antidepressants, like SSRIs, can reverse this abnormality by increasing synaptic strength, release of BDNF on other neurotrophic, and recovery of synapses. So for ketamine, it seems that ketamine works in both ways. First, ketamine induced a glutamate surge during infusion, and this glutamate surge could be by disinhibition of the interneurons, because ketamine is an MDMA antagonist, and this is here, we can see it on this receptors, this inhibition of this receptor, which will lead to glutamate surge. And the other, that more recently, it seems that one of the metabolites of ketamine, the HNK, Z6-HNK, seems to directly lead to this presynaptic release of glutamate and a glutamate surge. And on the other hand, ketamine is also an NMDA antagonist, so it's also protective in a sense because it's blocked extrasynaptic NMDA. So if you have a spillover, you don't have the excitotoxicity that you may have under normal conditions. So in this sense, ketamine is exactly like acute stressor. It will increase the glutamate release, but the good thing about ketamine that it's acute. What we believe and what we know, at least from preclinical data, that if you give the animal ketamine once a week, or maybe twice a week, or 3 times a week, it's going to be beneficial to the brain. But if you give ketamine to the animal on a daily basis, it's going to lead to excitotoxicity. And this is similar to acute stress. If you have acute stressor, it's good for the brain. It will enhance cognition, and it will make the brain stronger in a sense and more resilient. But if you subject the animal to chronic stress, especially unpredictable stress, on a daily basis, they're going to have excitotoxicity.
2 minutes.
So just to give you a sense of how we can test this in human studies. So here we see data from functional connectivity comparing the brain of major depressive disorder to healthy control. And we see that patient with depression, they have significant, the blue is a reduction in global brain connectivity in the prefrontal cortex. And we think this reflects the synaptic disconnectivity that you see it in the prefrontal cortex of animal. On the left, we see a comparison between treatment-resistant depression and healthy control. And we see, again, in the prefrontal cortex, you have this blue cluster where they show reduction of global brain connectivity in the depressed subject. We treated those subjects with ketamine, and 24 hours later, when they achieved response, we repeated the same scan. And we see on the right that most of the clusters that were abnormal at baseline, they become normal after treatment. So we have no significant difference between depressed and healthy subjects after a treatment in most of the clusters. So if we look at the changes in global brain connectivity, and we see if this is limited to those who responded to treatment or those who did not respond to treatment, again, we see that the increase of global brain connectivity were mostly in those who achieved response. And this is another way of looking at the data. So if we look here on the top left, we see in red the number of voxels that were significantly different before treatment. And we have more than 2,000 voxels. And in blue are the number of voxels that they are significant after treatment. And we were left with only 300 voxels that they abnormal compared to healthy control. On the right, we see that before treatment, the red are the healthy control and the blue is the depressed subject. So we have connectivity. We see a left shift. On average, depressed subject, they have this reduced global brain connectivity in the prefrontal cortex. And after treatment, we see on the left those who respond to treatment. They have normal functional connectivity compared. So we see the overlap between the blue and red versus those who did not respond to treatment. They continue to have reduced global brain connectivity.
You have to come to conclusion.
One last slide. So this is a replication study that in a separate sample, we see the same reduction in the prefrontal cortex, and we see that ketamine increased this global brain connectivity. And thank you.
Raquel? Here's the pointer.
Thank you. Good morning. It's so nice to see my friends and colleagues. Is it not on? How's that? Better? Can you hear me still? People are saying turn it up. I don't have control to do that, but maybe the guys can. Could the volume go up just a little, please? Well, I'll keep talking so you can test it, and I would love it for my slides to come up. Oh, you want me to use this instead? Okay. Sorry, I didn't get the memo. I'm going to give you that. Oh, yeah, oh, dear. That's a little better. Okay. Next question, how do I get my slides up? Oh, but they're not on my screen. That's going to be a little bit of a challenge. Okay.
That's my screen.
All right, never mind. It is so exciting to be here today. I'm Dr. Bennett. Can I have the next slide?
Use the pointer.
Oh, to where? There?
Anywhere. Just here.
Phil, will you help me, please?
Yeah. So it's this way.
I'm thinking we probably should have practiced more before today, but it's okay. Thank you. Okay, I wanted to say that I am a psychologist and a ketamine specialist. I work in partnership with physicians who prescribe and administer ketamine. I'm not allowed to do that as a psychologist. But my specialty is in working with people who have severe depression or who are on the bipolar spectrum or who are actively suicidal. And I got frustrated with how slow conventional treatment was for this population. And I was interested in what could be done that was faster, and I became interested in ketamine. And in addition, over time, I became interested in using ketamine as an adjunct to psychotherapy for self-exploration. I've been fascinated by it for about 15 years since I first encountered it and first noticed that it appeared to have a very rapid-acting and robust antidepressant effect that I hadn't heard about at that time, and I wanted to find out, how is it doing that? And that somehow led to this moment. So here we are. And I also wanted to mention that I run the international conference on the use of ketamine in psychiatry and psychotherapy. Let's give this a wing-ding. Okay, so I'm going to just try to be short and sweet and to the point. I have a couple of things that I wanted to say today. The first thing that I wanted to point out is that ketamine is used in a number of different ways in medicine and in psychiatry and in psychotherapy, and that the populations are quite different and the treatment is quite different. The way that we use ketamine to treat depression has some overlap with, but is also different from, the way that we use ketamine for spiritual exploration. And it has some similarity to, but is also different from, how ketamine is used to manage physical pain. And it's also similar to, but also different from, ketamine for depression is similar to, but different from how ketamine is used as a surgical and procedural anesthetic. And so in listening to the talks, it's important to be thinking about what are the goals of treatment for the patient that we're discussing, and what is the route of administration that we're talking about, what's the dosing strategy that we're talking about, and why. Who is this targeted for? I just wanted to make that distinction because otherwise it's easy to get confused. There's a lot of information. I'm not going to talk about all of these, but I did want to point out that there are at least 7 different established dosing strategies for the use of ketamine. I'm going to be talking about 3 of them, the 3 that are mostly used in the treatment of severe and refractory depression and other psychiatric disorders. But I just wanted to point out that there's a lot of different dosing strategies. Unfortunately, we don't have time for all of that today. So let me just clear up a couple of things that I get the same questions over and over again, and I actually have gotten this question a number of times this weekend. So let me just cut to the chase. The National Institute of Mental Health and also recently the American Psychiatric Association have been publishing results about the use of ketamine in the treatment of people with severe depression who are getting what we call low dose, that's air quotes, low dose ketamine administered by IV. And so here's a picture of someone getting their IV low dose ketamine treatment. I'm not going to go into great detail about this, but what I really wanted to say about it is that this dosing strategy has been pretty well established as being a very helpful adjunct to conventional treatment. What I mean by that is ketamine as an adjunct or in addition to psychotherapy and medication. And what's important is that this strategy, this way of using ketamine, is specifically designed to be sub-psychedelic, meaning on purpose the patient is not having psychedelic experience. That's the purpose of this dosing strategy, is to avoid having psychedelic experience. And I have a lot I want to say about that. I'll save that for another day. But I wanted to just point out that when doctors are talking about the use of ketamine in this way, they're thinking about ketamine purely as a pharmaceutical, as a medication where the medicine is doing all the work, but the patient doesn't have to do all that much except show up to the appointment. And it's not uncommon that patients are invited to pop on their headphones and rock it out, listen to music during their treatment. And I'm not saying there's anything wrong with that, but I want to be clear that that's a specific way of approaching ketamine treatment, but not the only way. Okay? Let's keep going, because time is short. A different way of using ketamine in the world of psychiatry is using a little bit more ketamine, a moderate dose of ketamine, And in this case, we're using the ketamine as a lubricant for psychotherapy. So the patient is relaxed on purpose by the ketamine, and we're using the time to go more deeply, using the ketamine session to go more deeply into material that the patient has been working on in psychotherapy, but maybe hasn't quite been able to get to yet, or maybe they're feeling really stuck. And I want to be clear that this is a different approach to using ketamine than what I just said a second ago. And I also want to just tell you honestly that I'm not convinced that ketamine is necessarily the best tool for this job, and it's certainly not the only tool for this job, but it's a legal tool for this job. So for now, this is what we got, and so this is what we're doing. It's perfectly legal. Here's a little bit more information on that. And what I want to say about it is that when we're working from this paradigm, when we're working in this way, using ketamine like this, we think that the thing that is helping people with their depression is not only the chemical effect of the ketamine, but also the effect of the deep psychotherapy. So it's the content and the relationship and what happens interpersonally between the therapist and the patient that is helping or enhancing the therapeutic effect of the treatment. This has not been studied, but this is the idea behind it. I just wanted you to know that. Okay. I also want to talk about what we're calling high-dose, air quotes, high-dose psychedelic ketamine treatment. This is where we're administering ketamine at a dose that's approaching the anesthetic dose, where we are inducing psychedelic and mystical experiences on purpose. People who work from this paradigm believe that it's the content of the visions, the mystical visions, that have healing properties in addition to the other things that I already mentioned. This has not been well studied. It's controversial. There's a number of qualitative papers about this or anecdotal papers about this that suggest that this is helpful for some patients some of the time. I want to add that I'm talking only here about people with severe depression. I just think this is a phenomena and a treatment strategy that's just begging to be studied more. Let me just show you the next slide real quick. So that's what I want to say about this. And I just want to reemphasize that the basic paradigm here is a shamanic or a psychedelic paradigm, where the psychedelic visions are part of the therapeutic effect in helping people with their depression. How am I doing on time, Phil? One more. Oh dear. Okay. I'm really sorry that I only have one more minute, but let me just wrap this up real quick by saying that this is the same information I just presented in a table format, emphasizing that there are different paradigms, different approaches to ketamine treatment. And if you're a patient, particularly a patient with severe depression who's looking for treatment, please ask your provider, what paradigm are you using? What dosing strategy are you using and why? And if you're a provider, what dosing strategy are you using and why? And please be explicit about that and explain that to your patients. I also just want to say, people ask me all the time, which one works the best? And the answer is, it depends. It depends on the person. Different things work well for different people. I wanted to touch very quickly in 30 seconds or less on some of the prominent themes in high-dose ketamine. I don't really have too much time to do that, but ask me later. But people talk, but I'm just going to skip that. But I'll just show you real quick. You can take it in with your eyes. Things that people talk about in high-dose ketamine treatment for depression. Okay, I'm going to just pop to the very end here and say that I do run the international conference on this topic, on the use of ketamine in psychiatry and psychotherapy. It's in November. It's here in the Bay Area. Please look it up on the website or catch me later if you'd like more information about that. Thank you.
Go together.
Oh, okay.
You want to go together?
I'm sorry we missed some of those last slides, Raquel. Those look really fun. Like we would have. So I'm Richard Roston. I'm a psychiatrist at Kaiser. When Phil asked me to talk on this panel, I asked him what I should talk about, and he said, "It doesn't matter, just have fun." And I thought, well, talking in front of 100 people, hundreds of people, is not my idea of fun usually, but so I did think I would talk about the history a little bit of how IV ketamine came to be, because I think it's a very, very versatile medicine. It's a very, very versatile medicine, and it does a lot of different things. It's a dissociative anesthetic. It can work for pain control. People can have very profound experiences with it. And how is it that we are now using this for depression? And how are you, at a large healthcare system like Kaiser, how is it that we are now using this medicine, especially since there's all this potential for psychedelic effects? And it's sort of surprising that an institution like Kaiser would be maybe allowing something like that. So I like to think of it sort of as a gateway drug to other psychedelics within the medical profession. So, yeah, I mean, I think Raquel pointed out that this is the first medicine that's actually in clinical use that has psychedelic effects. Everything else that we're learning here at this conference is all under research, and right now, just down the road, where people are having psychedelic effects. And as Raquel pointed out, the psychedelic effects that people are having are minimal. Where there's this protocol that we're going to be talking about a little bit, is developed in a way to really minimize the potential for changes in consciousness that could be profoundly healing. So I'm going to start with just talking a little bit about the research and how that allowed for practitioners in the community to start using this protocol. It all started with a research article in 2000. A group from Yale, Berman was the lead author, stumbled upon its effects just upon chance. They were actually using ketamine as a model for psychosis. And while they were using it that way, they noticed that people were feeling a lot better days afterwards. So they put together this very small trial, just 7 patients, and they made up some protocol. I sort of learned from the grapevine they came up with the 40-minute time because it would fit well in an hour session, so they could get the nurses together. And so they just made this up, 0.5 milligram per kilogram over 40 minutes. And it turns out it's probably pretty lucky because it's probably very close to optimal dosing as an antidepressant, as Chadi was talking about, to get that big glutamate burst. Probably that amount is close to optimal. There are further studies being done right now to sort of see if there's other better dosing. I think it's important to point out that there's the bias against the changes in consciousness. Even in this article, you can see clinical applicability of this strategy may be limited by its psychotomimetic effects. So you can see the bias there. The research after the 2000 study, that study was pretty much just, I wouldn't say ignored, but not many people in medical establishment really knew much about that article. It was sort of something of interest, but it was in 2006 when it was replicated with 18 patients, and they got the same incredibly robust response that just taking a group of patients where nothing else has worked, no other medicines have worked, very severe depression, they feel better just a day or two later after using this very low dose. So a lot more study has been done since that 2006 replication, enough so that the American Psychiatric Association Task Force a year ago or so acknowledged ketamine as a very unique antidepressant. And Even just last month, there was a consensus statement on IV ketamine use. It was in the Journal of in JAMA, and so they actually gave some guidelines around how to use IV ketamine. How much? So I think I wanted Alison to maybe jump in a little bit here to talk a little bit about how that consensus statement came around, because she was actually very instrumental. Alison is the director in region at Kaiser for ketamine therapy. And she's really paved the way for us at Kaiser as well as nationally. So, and she was part of that consensus, making that consensus statement. And I think her telling a little bit about that story might be of interest. So, what's that? Well, I'll show more of my slides then.
Okay, thank you, Richard.
Yeah.
So just briefly, so how did this all come to be that we had ketamine at Kaiser? Well, I had been following, I used to be a scientist. I was at Mount Sinai and doing a completely different career for many years. And then I'd been following Sanjay Matthews' work on IV ketamine. And I happened to go to a talk at UCSF by a community provider who said, it works, it's fantastic, but he didn't give any data. And all my scientific background came roaring up to me, and I thought, we could do this at Kaiser. We could do this really well, and we could keep great data, and we could really, this is something we could do. And thanks to the passion of Richard and myself and our chief at the time, Mason Turner, we got the impetus to get it going. Right about that time, so in 2013 in Banbury, Connecticut, a series of meetings had started, funded by Big Pharma, with researchers, the people who'd been doing the primary research into IV ketamine. And basically, as we know, ketamine has a branding problem. So what they were saying was, well, we need to come up with a different type of ketamine. We can call it something different. It'll be ketamine-like. And that'll be more palatable as an antidepressant. So in 2015, though, they met in 2014 and they were closed proceedings. And then in 2015, bowing to sort of this enormous pressure from patient advocacy groups, they invited community practitioners, Steve Levine and Glenn Brooks, as well as ourselves. My chief is representing Kaiser, and Dennis Hartman, who is a leading patient advocate for ketamine therapy. And it was at that time that everything kind of started to shift, and the APA made a promise that they would publish these treatment guidelines, which fell short of an endorsement. If you read them, they're not an endorsement, but they are guidelines. Although, shortly thereafter, in an interview on NPR, the lead author of those articles said, how do you not give this drug to people? So there's still tensions within the APA on this. So anyway, that's my little 2 bits.
Is that for total? Okay, so I'm going to really go quickly over this. Those guidelines, I just wanted to point out a few quotes from those guidelines. There's still this bias against the psychedelic effects. You can read, if indicated, restraints to manage potentially dangerous behavioral symptoms. It's kind of crazy. We've never seen anything like that while we're treating patients with this. So there's still this bias. I think I'm going to skip some of these slides. Yeah. I just want to put this as a hypothesis for ketamine and how to think about it and its diverse effects. I apologize that some of the writing there is really tiny. The first bubble is its antidepressant effects. Then the second bubble is the psychedelic effects. And then the third bubble is its dissociative anesthetic. So the higher the dose you go, the more of each of one of those effects you get. And so the actual circles, the way I put them, is not precise. We're all sort of trying to figure out where those might lie, but I think it's a useful way of thinking about ketamine, that the higher the dose you go, the more of each one of those effects you get. And there is some overlap, and we do see that in the clinic, that as patients are having some changes in consciousness, sometimes very profound and sometimes very healing. And at Kaiser, we really are very limited in terms of how much time we can, let's see. This is just a slide about how we work with set and setting in our very large system, and we do our best to actually bring about or work with the psychedelic effects and the changes in consciousness. But it's hard to because we have limited resources. So, thank you.
Let's open the floor.
Yeah.
Any questions from the audience? Dialogue?
Feel free to use this mic for questions from here.
We can't really see you. So.
I can't see you either, but in my work, that's not a problem. So my question is, first of all, thank you guys for all your work. It's phenomenal, and thank you, Phil, for the book. It is phenomenal and really super. I'm interested in the data behind the potential side effects of bladder toxicity. We read about it. Where does this come from? Is this in chronic users? Is this in addicted people? Or has been any reports of bladder issues in people who are treated in the kind of protocols that you guys are showing on the screen there? Thank you.
Quick.
Sure. Do you want to take it?
Go.
Okay. Thank you. Thank you for the question. So there does appear to be possibly a link between excessive ketamine use and cystitis or irritation of the bladder. It's mostly seen, or most of the data that we have about this comes from people who are in residential treatment for ketamine substance abuse. And so the data is confusing because a lot of the people are polysubstance users and their histories are a little bit unclear. So far, we've minimally seen it in people who are receiving medically supervised ketamine. I'm not aware of any reports of people getting cystitis following an exposure from ketamine used for anesthesia. But I am getting a lot of calls, not a lot, I've gotten about a dozen in the past year, from people who have either been self-medicating or using medically supervised ketamine over time for their depression. So it is a concern. We need more information. Does that answer your? So bottom line, we don't know.
We've seen it in one person, perhaps, on a first-time treatment. The statistic in general is 1 in 100 within the clinical format, and it's generally been reversible.
Part of your informed consent.
It is.
Thank you so much. I really appreciate everything that you all had to say. But I'm curious: is there some if a person has had a lot of experience, say with street ketamine, does that somehow preclude getting treatment later? Would that experience sort of make it impossible to have beneficial therapy later with it? Is that something that anyone has ever done any research on? In other words,
we've had a few people who are ketamine wise in our life, but not excessively, and we don't really work with people who have ketamine addiction.
Right.
We're not trying to foment that. We're trying to do everything to prevent that.
No, I'm not so much saying for people who are practicing that. I'm just saying, would the experience make it impossible for you to benefit from this later? That's my
no,
question.
because if you're doing psychotherapy, it's different than the
Of course.
other. But if you know the experience and you've done that myriad times, you may not have much of a new effect.
Right. Thank you so much.
Hi, I was just wondering if you knew of the existence of the ketamine analog methoxetamine, which is substantially more potent and is said to was designed to try to minimize the urinary bladder tract effects and whatnot.
How about that? Okay. So we've looked into it a little bit, and we also have some self-reports about it. So one thought was potentially that because the methoxetamine psychedelic effect, using it in a higher dose range, lasts longer than the ketamine effect, we were hoping that maybe it would have a more robust antidepressant effect. This has not been formally studied in an academic setting, but I want to tell you that so far we have found that to not be true. I don't know, I can't speak to the cystitis question because we don't have enough data, but there's no evidence at this point that suggests that methoxetamine is a better antidepressant than ketamine.
And also it is addictive as well. I've seen 2 people with methoxetamine addictions, and it's illegal, so we have ketamine. We're happy to have ketamine.
Thanks for that, Phil.
Hey, good morning. Thank you for being here. And my question is, how do you manage the use of other antidepressants, SSRIs, benzodiazepines, antipsychotics for people who are going to be entering a ketamine infusion protocol?
Using the NIMH protocol, people don't change their medicines, so people can continue almost all of their medicines while they're getting this treatment. We typically, if there's a really good response, we actually ask people to not change any of their medicines for some months, and then if they continue to do well, we have them slowly come off of it. There was some question about benzodiazepines. I think we're loosening a little bit in terms of how much.
There are a few questions that are out in the world. One is lamotrigine antagonism of the ketamine effect. May be true. If you stop lamotrigine, you have to restart it again within 2 days, or you have the potentiality for the Stevens-Johnson reaction. There's controversy over use of Adderall or other stimulants. That day, we don't do that. And there is controversy over benzos.
Yeah.
We stop them. We don't have people do benzos the same day, but some people use benzos in their practice, like giving Ativan for agitation before that. We don't see the need for that because we do provide the lozenge format, which takes away the anxiety at a low dose. So lots of controversy in the field.
Yeah, so the vast majority of medicines, okay, gabapentin, Lamictal, and benzodiazepines, there's some controversy around them.
Thank you.
Yeah.
Thank you.
Thank you for the talks. Considering that in the near future we will probably have psilocybin available for the treatment of depression, what would be the advantages and disadvantages of ketamine over psilocybin?
We're building a toolbox.
Yeah.
In the toolbox, right now we have one drug legal, ketamine. Ketamine is a short-acting, powerful experience. Psilocybin's a longer-acting, powerful experience. It does a different thing. Drugs have signatures. At the same time, we might have MDMA in the toolbox. MDMA is a powerful psychotherapeutic and pathogenic experience. We could use all 3. We could bring in a bunch more. So let's enlarge the toolbox.
That's what I was thinking about there. Thank you.
I'm sorry, we're at time now, so thank you all so much.
Thank you.